So my name is Michael Khoury. I'm a pediatric cardiologist, for those of you that I don't know, that specializes in pediatric heart function and transplantation with an interest in cardiac rehabilitation. And I have the great pleasure of introducing Amanda Krysler today. Amanda is currently a second-year medical student, or wrapping up her second year of medical school at the University of Alberta. She did her bachelor's and master's of science in pharmacology at the U of A. And I've been fortunate to have her join me on our MedBike research team last summer and for the coming summer as well. And through this work, she's completed a systematic review evaluating telemedicine exercise interventions, which she presented at the most recent American College of Cardiology scientific sessions. And she continues to be involved in our two MedBike randomized controlled trials that are ongoing, one of which is in pediatric heart transplant recipients. Her summer research has been funded by Alberta Innovates, WICRI, and the Mac Gayson Studentship. The floor is yours, Amanda. I'll leave it to you and take it away.
All right, so thank you for that kind introduction, Dr. Khoury, and thank you for the invitation to speak today. So today we'll be exploring the promise of cardiac rehabilitation for the pediatric transplant population. So I have no personal or financial disclosures, and today we're going to be going through the following objectives. We'll start with outlining the current limitations in exercise capacity and physical activity for pediatric solid organ transplant recipients. Then we'll be reviewing the evidence basis of cardiac rehab in children and adults, followed by reviewing the potential impacts of cardiac rehabilitation and the current work aiming to evaluate exercise interventions in the pediatric transplant recipients. So why are we talking about cardiac rehab in the context of pediatric solid organ transplant recipients? Well, overall, adult and pediatric solid transplant organ recipients have a reduced exercise capacity compared to age-matched controls. This has implication on long-term graft failure and cardiovascular health. These patients also have increased cardiovascular disease risk factors, reduced physical activity levels, and a reduction in health-related quality of life. So I just want to start with some definition slides, as we'll be discussing exercise capacity quite a bit throughout the talk. So how do we measure exercise capacity? Well, peak VO2, or VO2 max as you might see it, is the gold standard for measuring cardiorespiratory fitness. Most often, this is measured during a maximal fitness test, such as a cardiopulmonary exercise test or a CPET. So during this test, gas analysis measurements of respiratory oxygen uptake, carbon dioxide production, and ventilation are taken while the patient is undergoing a graded exercise test. And then at maximal exertion, peak oxygen consumption, or peak VO2, is directly measured and reflects aerobic or exercise capacity. All right, so now we're going to move on to the impact solid organ transplant has on exercise capacity. One example that outlines this nicely is a comparison between 16 patients on hemodialysis and 35 patients post-kidney transplant. Exercise capacity as measured by peak VO2 in the study remains significantly lower than age-matched controls in both the hemodialysis and post-transplant group. As well, this trend was also reflected in skeletal muscle strength, as shown in the figure on the right. Similar results to this study are seen across different organ transplant groups and have been extensively studied in the adult population. Okay, so what about the pediatric population? Well, exercise capacity and physical activity is also reduced in this population. In a study of 20 children who underwent a physical activity assessment and an exercise stress test, median levels of moderate vigorous physical activity, or MVPA, was only 7.6 minutes per day, and all participants failed to meet existing physical activity recommendations. Moreover, their exercise capacity was significantly reduced, a finding previously shown in numerous other studies. Similarly, a study looking at a younger population of pediatric heart transplant patients with around a mean age of 9.7 found peak VO2 to be significantly lower in the 24 patients compared to the 25 age-matched controls. This finding was reflected in 3 previous studies looking at exercise capacity in older pediatric patients with mean ages of 15 and 13, as shown in the summary figure on the right. So you may be thinking, well, that makes sense for heart transplant patients, but what about other solid organ transplants? Well, a study done by Krysler et al. Looking at 25 kidney and then 11 liver pediatric transplant patients, results showed consistent findings of decreased exercise capacity across the 2 transplant groups. So the study used something called PACER as a measure of cardiorespiratory fitness. And essentially, they just measure the amount of laps that you can do until you get fatigued. And then that's done as a surrogate measure of exercise capacity. And then that's kind of compared to the standardized age match amount of laps to see if they meet that kind of age predicted healthy fitness zone. So the average for both transplant groups was around 50% of the age matched healthy fitness zone. And then on the figure, the zone is kind of shown by two black lines, with the lower line being the lower end of the zone. So as you can kind of see here, none of the males and only one of the females in both the kidney and the liver transplant group met the expected zone. As well, kidney transplant and liver transplant recipients also only achieved approximately 75% of the age and sex reported normal values for peak VO2, which was assessed through a graded treadmill exercise test. Finally, the patients also self-reported their physical activity time, and overall only 8% of the after-school time was actually being spent participating in physical activity for each of the groups. Finally, a recent study in 2022 looked at physical performance across multiple solid organ transplant recipient groups, and they found compared to healthy controls, all the physical performance categories were significantly lower for the combined pediatric transplant group, except for the sit and reach test, where recipients performed around similar to controls. So in summary, from all these studies, we've seen that a decrease in exercise capacity, physical performance, and physical activity time are also seen in the pediatric solid organ transplant populations. So why do pediatric transplant recipients have reduced exercise capacity and physical activity levels? Well, let's explore some factors that limit exercise capacity as described in the Joint Position Statement of the Canadian Society of Transplantation. So besides the fact that transplant recipients themselves often have decreased exercise capacity due to primary organ dysfunction, this does not always improve post-transplant. In fact, exercise capacity remains reduced to about 40 to 70% of predicted in the majority of adult and pediatric transplant recipients. Some factors that may lead to persistent decrease in exercise capacity include skeletal muscle weakness, cardiac and muscle deconditioning, impaired vascular function, cardiac autonomic denervation, secondary effects from immunosuppression, and finally, an overall reduction in physical activity levels. Add into that, the majority of children in North America are not meeting the recommended amount of physical activity per day, which means we cannot rely on existing school structures to supply them with enough physical activity throughout the day. Additionally, aside from the factors that impair physical activity levels for youth in general, youth with heart disease and chronic health conditions may have real or perceived restrictions imposed on them by the medical team, their family, their teachers or coaches, or self-imposed restrictions placed on themselves. They may have feelings of exclusion, health-related anxieties, negative perceptions from peers, or there may be parental feelings of loss of control. So what are the implications of reduced exercise capacity and physical activity levels in transplant recipients? Well, we all know that exercise is good for you and that we should all be making time to make it into the gym. But what can exercise do for kids, and why is it so important to hit that average 60 minutes a day? According to the Canadian 24-hour movement guidelines, there are quite a few benefits to making sure you're getting enough activity throughout the day. Not only do you increase your cardiorespiratory fitness levels, cardiovascular risk factors and metabolic health can also be improved. It's particularly important for transplant patients as they are at higher baseline risk for cardiovascular disease. Physical activity can also improve bone mineral density, depression, and overall cognition and quality of life. So now that we know the overall benefits of exercise, how does this relate to the transplant population? Well, in a study of 49 adult heart transplant recipients, overall survival and survival from cardiovascular death was found to be inversely associated with a BMI more than or equal to 28 and a ventilation per carbon dioxide production slope of more than or equal to 47, which essentially is just a measure of ventilation efficiency that we can get from the CPET as well. Among the 14 deaths that occurred in the study, 10 were cardiovascular. Notably, both of these independent risk factors are potentially modifiable through exercise and lifestyle interventions. A more direct correlation of survival with exercise capacity was found in Yardley's study of adult heart transplant recipients. In the cohort of 178 patients that underwent a CPET, there was a median survival of around 12 years. When peak VO2 levels, though, were above median, this was strongly related to an increase in survival time to 16 years. As well, there was a cohort of 133 patients that took a short form health survey, which essentially is a questionnaire that quantifies 8 sections of health-related quality of life. And in this cohort, the median survival time was 10 years. When physical functioning scores, which is one of those 8 categories, was above the median, this was strongly related to an increase in survival time to 14 years. So in summary, both an increase in exercise capacity and health-related quality of life resulted in increases of median survival time to the adult heart transplant population. Furthermore, in this study, they were assessing the impact physical activity time has on overall and cardiovascular mortality. Adult kidney transplant patients were placed into 3 groups of 180 participants, depending on their self-reported physical activity levels. So they either were placed in active, moderately active, or inactive groups. And then associations between these groups and survival was then determined with adjustments for age. Cardiovascular death incidence was significantly decreased as the physical activity levels increased, so going from inactive to moderately active to active groups. This trend was also seen with overall mortality. As well, independent relation of its age, physical activity was also inversely associated with a history of cardiovascular disease, insulin concentration, triglycerides, and serum C-reactive protein, which is just a marker of inflammation. So what about in the pediatric transplant population? Although the evidence is not as comprehensive, we do see similar trends in exercise capacity and physical activity as a marker of cardiovascular fitness in this population. So this study looked at 22 pediatric kidney transplant recipients and found this population had a decrease in both peak VO2 and physical activity levels compared to the reference population. As well, 73% of the 22 kidney transplant recipients were currently hypertensive or they were already on an antihypertensive medication. And also 1 of 3 of them were overweight. So we talked a lot about the impacts of decreased exercise capacity, but what about health-related quality of life? So a study in 2014 looked at adult kidney transplant recipients in order to determine the effect of physical activity levels on perceived health-related quality of life. They compared 118 active and 79 sedentary transplant groups to 120 active healthy controls. The sedentary kidney transplant group reported significantly lower scores than both the active transplant group and the healthy controls in multiple areas of health-related quality of life. These included physical functioning, physical role, general health perception, vitality, and emotional role. Additionally, active kidney transplant recipients actually scored higher than even the controls in social functioning and mental health. So this outlines how important it is even to get moderate physical activity, as you can have an impact not on just physical health, but also health-related quality of life. Similarly, this was seen in adult liver transplant patients, where the active group scored significantly higher than physical functioning, physical role, bodily pain, and general health areas. They then controlled for comorbid conditions because as the inactive group they found had a significant increase in hypertension and osteoporosis. So by using a regression model, they found that both physical activity and the number of comorbid conditions were each independent risk factors for a decrease in health-related quality of life scores. So this trend is also reflected in pediatrics, where a study by Feldman et al. Using the Pediatric Quality of Life Inventory Questionnaire saw a significant relationship between emotional and physical functioning scores. In particular, pediatric liver transplant recipients were significantly more likely to score physical health questions as 3, often a problem, or 4, almost always a problem, compared to controls in most of the categories as seen on the figure in A. And this was also seen in B with the parental scores, which were actually significantly increased in all the categories compared to controls. Similarly, a pediatric study of 38 kidney transplant recipients found that BMI and exercise capacity, measured as peak VO2 in the study, were independent variables for changes in health-related quality of life and mental health, respectively. So in summary, we've seen in both adults and pediatrics, a decrease in exercise capacity and physical activity seem to be negatively impact the patient's overall perceived quality of life. Okay, so what do we know so far? So we went through quite a bit. In summary, we've learned that both adult and pediatric solid organ transplant recipients have reduced exercise capacity and physical activity time, which can be markers of cardiovascular health and is related to a decrease in health-related quality of life. We also saw that decreased exercise capacity and physical activity levels are associated with increased mortality in the adult transplant population, and a low perception of physical health is also associated with an increase in mortality. In the pediatric transplant population, we do not have nearly enough studies to correlate exercise capacity and health-related quality of life with mortality. However, we do know that all the positive impacts on cardiovascular health and quality of life that exercise has in the healthy pediatric population. And we also know that there's a decreased perception of physical health, decreased physical activity levels, and an association between exercise capacity and cardiovascular health in this population. Okay, so how do we change this? So we're going to go look back at this slide about all the factors that are limiting exercise capacity, and look at how we can address almost all of these with a comprehensive rehabilitation program. So by incorporating resistance training, we can improve upon muscle strength. And in case of lung transplantation, this may also include inspiratory muscle training. Targeting modifiable cardiovascular disease risk factors, as well as using aerobic exercise programs, can improve upon vascular functioning and overall deconditioning. Improving physical activity levels can be addressed twofold. One, we can address the safety concern by providing monitored exercise programs. As well, having an approach which makes exercise enjoyable, especially for children, will be important for adherence. Finally, we can address overall health-related quality of life through a multidisciplinary approach with nutrition, activity, and psychosocial components. Okay, so we're going to transition now into what is the role of cardiac rehabilitation. So this is an already established secondary prevention strategy for addressing many of these factors that we've discussed. And although it's mainly studied and utilized in the adult population, there is an increased interest in trials surrounding adopting these programs to fit a pediatric patient base. So what is cardiac rehabilitation? The American Heart Association provides a nice definition, stating that cardiac rehab is a coordinated, multifaceted intervention designed to optimize a cardiac patient's physical, psychological, and social functioning, thereby reducing morbidity and mortality. Importantly, cardiac rehab is an established secondary prevention strategy. It's a Class 1 recommendation from Canadian, American, and European guidelines for adults with numerous forms of acquired heart disease, including unstable angina, myocardial infarctions, and heart failure. So often when we think about cardiac rehab, we think of exercise training. While this is a core component of cardiac rehab, there are numerous other elements that are incorporated, including a baseline assessment to help tailor needs to the patient, nutritional counseling and education, risk factor management, including the management of dyslipidemia, hypertension, and diabetes, management and navigation of psychosocial and vocational stressors, advice around instituting long-standing physical activity habits, and optimizing medical therapy. While many of these elements may not seem directly translatable to the pediatric population, they certainly can be adapted and tailored in a way that would benefit these patients. Although exercise training remains a central component, the comprehensive model of modern cardiac rehab is central to enabling patients to reduce their cardiovascular risk, foster and maintain their health promotional behavioral patterns, increase their mental health well-being, reduce their disability, and promote an active lifestyle, with the overall aim of improving well-being and health-related quality of life. So numerous studies have consistently demonstrated that cardiac rehab improves exercise capacity and reduces cardiovascular mortality and hospitalization following coronary events. This study, led by Billie Jean Martin from Calgary, looked at the impact of cardiac rehab attendance and completion on mortality and hospitalization, demonstrating significant reductions in those that completed the cardiac rehab program. As a result of the wealth of literature, specifically RCTs, randomized controlled trials, studying this topic in the adults, a number of meta-analyses have been published. A recent Cochrane meta-analysis by Anderson et al. Included 63 RCTs involving over 14,000 patients. The meta-analysis demonstrated that cardiac rehab resulted in significant reductions in cardiovascular mortality and hospitalizations, as well as improvements in quality of life. So we know this program is established in cardiovascular disease patients, but what about transplant populations? So in this follow-up Cochrane review by Anderson et al. In 2017, they did a review meta-analysis, and 9 of the included RCTs with 284 participants looked at adult heart transplant recipients using exercise-based cardiac rehab. The meta-analysis, as displayed in the figure, demonstrated an improvement in peak VO2 for participants undertaking the exercise program compared to the no exercise controls in the majority of the studies. This was also found in a more recent meta-analysis looking into more broadly at adult solid organ transplant recipients. This review included 21 RCTs of 739 participants who had received liver, kidney, heart, or lung transplants. So 13 of these trials looked at peak VO2 as its outcome to exercise capacity and found a significant increase in the exercise group compared to controls. As well, 7 of these studies found a significant increase in quadricep strength as well, and there was a trend of improved health-related quality of life. So now that we've seen the evidence for the adult transplant population, what about in pediatrics? Well, there is currently limited data available assessing the impact of cardiac rehab programs for heart transplant and other solid organ transplant populations. So with that in mind, I'm going to touch on some evidence that we have in the pediatric congenital heart disease population, and then I'll look at a couple of studies that have started looking at cardiac rehab in the heart transplant population. So what have the findings been of date of exercise interventions in youth with heart disease? So this work by Jonathan Rhodes in Boston was one of the earliest positive studies in exercise interventions in youth. They enrolled 19 children with moderate to severe congenital heart disease with reduced exercise capacity. Of these, 16 children completed the program. The program consisted of age-appropriate exercise consisting of aerobic and lightweight resistance exercises. Following the 12-week program, improvements were seen in 15 of the 16 participants, and these improvements were maintained for 6 months after completing the program. So with all that said, the evidence is still very limited for this population. So including the Rhodes study, there have been a number of exercise interventions in the congenital heart disease population. These studies have generally been limited by small sample sizes, inconsistent measures and outcomes, and a lack of randomization. There have been a number of systematic reviews that address this data. In the only meta-analysis on the topic, a mean improvement of 3.68 milliliters per kilogram per minute in peak VO2 across 5 studies was observed. The figure on the right is from a systematic review examining cardiac rehab in the pediatric and adult congenital heart disease population. Generally, it demonstrated a mild improvement in peak VO2. More contemporary systematic reviews have been performed that have generally demonstrated similar findings. It should be noted, though, that many of these studies do not have control arms. Importantly, in the published literature to date, there has not been any adverse event attributed to the exercise intervention for any patient with congenital heart disease. So there similarly has been a limited assessment of exercise interventions in the pediatric transplant population, but I will touch on 3 studies that have been done so far. So firstly, in this study by Patel et al., a 12-week home-based assessment involving an aerobic exercise program with 13 pediatric heart transplant patients was undertaken. The exercise program resulted in improvements in peak oxygen consumption at the top and then muscle strength in the bottom figure. Importantly, there were no adverse events reported in the trial. So a more recent study by Dilva et al. Did look at 2 groups of heart and lung transplant populations undergoing an exercise regimen either from home with parental supervision or in the hospital with PT-directed supervision. So this study used something called 6-minute walk distance as their measure of exercise capacity, which essentially just sees how far you can walk in 6 minutes, and it's used as a sub-maximal exercise test. So at follow-up at 3 and 6 months, the 6-minute walk distance was significantly improved from baseline in both the intervention group, with no significant differences between the groups. So finally, there's a recent Healthy Hearts trial that looked at live video conferencing supervised exercise interventions for 14 pediatric heart transplant recipients. So this 12 to 16 week supervised program consisted of both exercise and diet intervention. There was high adherence of around 89% for the exercise and 88% of nutrition sessions during the actual intervention itself. And this actually improved to 93% of exercise and 92% of nutrition sessions during the maintenance period. There were improvements in BMI, endothelial function, and daily consumption of fats after the intervention, while both VO2 max and functional movement scores were significantly improved and were also sustained in the maintenance period. As there was no comparative group, extrapolations of these results is very limited. However, the incorporation of telemedicine and cardiac rehab together is a promising idea, especially for pediatrics. Okay, so with all that in mind, what would an ideal pediatric transplant cardiac rehab program look like? So this kind of brings us back to the factors that we need to tackle with a comprehensive rehab program. We're going to dive a little bit more into the specifics of some of the factors, starting with what would an ideal aerobic program look like? So many of you probably heard of a HIIT program, or a high intensity interval training program. It involves short bursts of high intensity exercise, followed by rest periods of low intensity exercise. And this type of aerobic exercise program has grown in popularity because it not only yields improvements in peak VO2, but also power output. But it has not of yet been studied in the pediatric transplant population. So while the study of exercise interventions in the pediatric transplant population is very limited, this has thankfully been more extensively studied in the adult transplant population. Moreover, increased attention has been paid to determining the best modalities to improve exercise capacity, including the use of a HIIT program. As shown in the figure, HIIT involves repeated intervals of near maximal cardiorespiratory exertion with breaks in between. So this HIIT program was compared to a moderate continuous exercise program, which is a more traditional aerobic exercise program, in 81 adult heart transplant recipients in Scandinavia. So after 1 year intervention, both groups yielded significant improvements in exercise capacity, but the improvements in the HIIT program were actually significantly greater than the differences noted in the moderate continuous program. This study was then included in a larger systematic review and meta-analysis in 2020. So this was comparing moderate intensity continuous training and HIT. And the two studies that compared moderate to HIT, both were found in favor of HIT. We're looking at peak VO2 as their outcome. And then 3 studies actually compared HIT to controls, and all of them were in favor of HIT as well. So despite the lack of evidence in the pediatric transplant population, HIT seems like a very promising addition to an effective aerobic exercise program. And for adults, potentially in pediatrics as well, although we need more studies. So another target of the program would be skeletal muscle weakness. So this can be tackled by adding resistance training to an exercise program, as it will promote increased muscular strength and aerobic exercise. Similarly to HIT, the current evidence is limited to kind of cardiovascular populations, so more evidence is needed to demonstrate a positive effect in a solid organ transplant recipients. As well, one of the many challenges facing implementation of a cardiac rehab program, especially in pediatrics, is accessibility to facilities. While facility-based programs or hospital-based programs provide supervision of safety and compliance, they are often inaccessible due to cost and/or location. Home-based programs are more practical and provide an easy transition of care, but they are more unreliable as there is not direct supervision. Therefore, an ideal program would utilize existing telemedicine technologies to allow practitioners to supervise participants while providing a safe and fun exercise program for youth at home. So given all this, what would the ideal pediatric cardiac rehab program look like? Well, it would involve a dedicated exercise physiologist and incorporate an individualized approach to exercise that is age and ability dependent. It would also include dietary and lifestyle education and psychosocial support throughout. So after referral and a baseline assessment, patients either undergo inpatient rehabilitation, a hospital-based program, or a home-based program based on their needs and preferences. Each program should be about 12 weeks in duration with dedicated sessions about 3 times per week. And then after the intervention, repeated assessment should be undertaken to evaluate improvements. This may include exercise tests, measures of physical activity levels, or more advanced testing such as stress echo or vascular assessments. In addition, further studies are required to explore the impact of these programs on quality of life and functional measures. So what are the factors currently holding pediatric cardiac rehab back? These programs are currently underutilized due to lack of awareness, limited number of personnel, lack of evidence-based exercise recommendations, and other logistical factors to implementation such as expense or parental anxiety. Therefore, moving forward, we need to address the following limitations surrounding implementation of these programs for pediatric organ transplant patients. So there's a paucity of literature evaluating the impacts these interventions have in this population, and the available literature is limited by small sample sizes, lack of randomization, and inconsistent outcome measurements. As well, we lack studies which look at both pre- and post-transplant exercise training outcomes. And finally, we have no current research about the impact of HIT programs for pediatric solid organ transplant recipients. Therefore, key areas of future research include more RCTs with a adequate sample size, facility and home-based program comparisons, studies that leverage existing technologies, telemedicine technologies to allow for a home-based program with supervision, providing more engaging exercise options for pediatrics, and then also exploring unique exercise protocols such as HIT and resistance training. So with that, I briefly share with you some of the work Dr. Curry and the team have been doing to develop a home-based telemedicine program in the pediatric cardiac population. So in collaboration with the computer science department at the U of A custom pediatric remote bike ergometer known as the MedBike has been developed. So this custom telemedicine ergometer is linked to a video game platform and allows for networking of up to 4 patients per session. And it's pretty fun. I got to try it out before we sent it to one of the kids, and it was hard work. the wormhole part is actually your kind of HIT interval where you have to go as fast as you can. And the resident was playing a little trick on me and increased the resistance to like 100%. So it was a good time. This technology does provide medical supervision with a live bidirectional feed of patient video, audio, ECG, BP, and blood oximeter signals while enabling remote determination of patient workload through the bike ergometer. And then the long-term goal is to use this technology to improve patient exercise capacity and to positively influence patient and parental perceptions of the patient's physical ability. So this will combat kind of the safety concerns and parental anxieties. So thus far, the team has calibrated the MedBike to a standard CPET in 10 healthy adults. This demonstrated strong agreement between the med bike and traditional CPET ergometer. They then used the med bike to assess the safety and feasibility of an on-site high-intensity interval training program for 10 children with Fontan physiology. They found that the med bike was safe and well tolerated. They then studied the full home-based program in 2 youth with Fontan circulation and found improvements in exercise capacity of 50% and 8% of the 2 participants with no adverse events reported. So we now plan to recruit for 2 randomized controlled trials, one in children with congenital heart disease and one in children who have had heart transplantation. And the timeline of the study is as follows. Baseline assessment is completed with a CPET, questionnaires, and physical activity monitoring. Participants are then randomized into an immediate intervention with the med bike or a control arm for the 12-week intervention. Follow-up assessment is the same as baseline, and then they cross over into the opposite arm for a further 12 weeks, after which another follow-up assessment is completed. And then longer-term follow-ups will be completed around 6 and 12 months post-intervention to assess for long-term changes. So we're currently recruiting 10 to 18-year-old children with repaired moderate to severe congenital heart disease and heart transplant recipient trials. So in conclusion, youth and adults with solid organ transplants have reduced exercise capacity and suboptimal physical activity levels. Cardiac rehab may improve exercise capacity in children with solid organ transplants, but this requires further study. Increased physical activity levels may lead to improvements in exercise capacity and health-related quality of life in pediatric transplant recipients. Finally, future directions include randomized controlled trials, novel exercise strategies, and home-based exercise programs, as well as provision of non-exercise components of cardiac rehab. So thank you for listening, and thank you to Dr. Curry for the use of some of your slides that I used throughout the presentation, and we're both available to take any questions.
Thanks very much, Amanda. That was great, though I'm biased. So we have plenty of time for discussion or questions that may have come up. So I'll see if anybody has any questions, or while that's percolating, I could ask or raise a couple of questions. But any questions from the group to start? Oh, Simon, Dr. Urschel.
Hey there, great talk. Thank you so much. I had 2 quick questions for you. One is around the quality of life assessment. I don't know if you had a chance to look at kind of the generic, I assume you use something like PedsQL or so. Many of them are actually have questions that specifically target physical fitness. So they will always have a low score if somebody is not able to keep up physically as well. Do you have any plan to control for that? Because when we used that tool in the past with our transplant community, they would often say, yeah, I'm not as fast as the other kids, but I don't care about that. That's not relevant for me. So do you have any way to adjust for that planned in your study going forward?
I'll probably defer for the specifics to Dr. Curry, but I know that we're assessing both physical activity levels and a couple questionnaires for health-related quality of life. So I'm assuming that we'll compare the physical activity levels and see if that correlates with the health-related quality of life, and then also try to assess more of the non-physical functioning scores in the actual questionnaires. Dr. Curry wants to add more details.
It's a really good point that Dr. Urschel brings up. So 2 ways that we're trying to address this is by each participant is serving as their own control. So they do baseline and follow-up testing to see if there's any changes there, versus changes that may occur just in the control arm for participants that don't yet get the med bike. And then we're not only using a PedsQL, but we're also using a self-efficacy questionnaire, which is really where most of our interest lies. So the CSA PPA questionnaire is designed and validated in pediatric populations to assess basically the participants' confidence in their ability to participate in physical activities, which is really what we're getting at, with a centralized hypothesis that, you know, while we hopefully will improve exercise capacity following an intervention, our real goal is to enable these kids to want to maintain exercise and physical activity moving forward. And so we'll be doing long-term follow-ups regarding that.
Yeah, I think that's great. I mean, just to follow up with that, we have been doing for the past 10 years heart transplant family camp. And one of the things that we do there is having a big soccer game, like 50 aside, between 5 months old players and 85 years old players. And the biggest part of that is really to show them that they can do it, that they can exercise. And it's really great for the parents and the children to see that they can actually run around with the others as well. Can I just add there a quick question about the HIT? Traditionally, HIT has been very worried about, especially in the transplant, denervated hearts. Do you have any evidence that it's safe for those patients?
Amanda, you want to start?
Sure. Yeah, I think we not pediatrics, but I think we did show the meta-analysis of the HIT and adults, and that there was no adverse events reported. So that does show us that at least in adult studies, that it is safe for transplant patients to undergo HIT exercise. And I know specifically when I was doing some research that kidney transplants in particular were worried about high exercise and having graft rejection. But they did show that there was actually ability to have physical activity. And then for the med bike stuff we've done so far, it was safe and there was no adverse events associated with the HIT program. And so Dr. Creighton probably expanded a little bit more on what they did with the pilot study. But it was shown that it was safe and effective for kids that went underwent had congenital heart disease at least.
Yeah, it's a valid point though, to theoretically you push somebody to maximal cardiovascular intensity, it potentially could, if there would be adverse effects from exercise, it would be rapid sudden increase in exercise. So it's important to remember when we interpret exercise interventions in fragile or vulnerable populations, I should say, that these trials often have lengthy exclusion criteria. So before we go and prescribe HIT for all of our clinical patients, we have to recognize that some of the participants may not actually apply to our patient populations. And similarly, in our MedBike trials, we have lengthy exclusion criteria. So for example, if the patient has known arrhythmias or moderate or worse dysfunction or recent rejection, these participants are excluded from the trial. Despite that, like Amanda said, there's meta-analyses data of HIT in transplant, in heart transplant adult populations that demonstrates safety. And then Amanda's involved with another systematic review and meta-analysis, which the paper is just being finished now, that updates this and also looks at it across the whole heart function and transplant continuum, and found no differences between HIT and mice or aerobic exercise or controls versus in transplant recipients. So we're quite confident that it's likely to be as safe as regular exercise. But great question. Sherry Logan.
Hi, thank you. Wonderful presentation. It's very exciting to hear. My daughter is a liver transplant recipient. She had her transplant 13 years ago at the age of 2. And at that time, we did not have, or I wasn't aware of rehabilitation for her. And so I can speak to Dr. Ischel a little bit about just sort of the lived experience in that, a year after her transplant, she was still this like fragile little girl that wasn't really all that active. And part of, a parent, you're very concerned about what she can and cannot do and the limitations. So we bought a cottage and there was kids everywhere that summer. And she went from this little fragile kid to barely keeping up, but participating, and her quality of life just went through the roof. And so did ours in seeing that progress of physical activity made on her. So, and from there, it just spiraled to build the confidence that she could actually do this. At the age of 4, she ran a 5K, run, and, it just continued with the rest of her life. And while we continue to have, we've continued to have setbacks along the way, we don't start at ground zero. We pick up where we are and we continue to move forward with the tools and resources that we have learned along the way. So I'm so glad you're doing this research. And I wish it was around when we first came into transplant. So thank you so much for this. I think it's amazing.
That's an amazing story. It's so different to have a lived experience versus just numbers on a page. Being able to actually say, I saw this different in my child when they were able to do some physical activity is just so important. And I know that getting to watch med bike trials and getting the kids to actually do the trial itself just is so much fun. And I know even when I was doing the like bike, you have to like follow the animals and you have to like go through the wormhole. And it was a lot of fun. And so I'm excited to kind of work on this in the summer and just see the difference in these kids from beginning to end.
Yeah, Sherry, thank you very much for sharing that. It's really helpful to, always consider the patient context in mind. And your story is exactly what we've seen and what Dr. Urschel has far more experience than me at this transplant camp that he runs, which it's truly remarkable. I've only had the chance to go once before the pandemic hit. And hopefully it carries on in the coming summers, because it really is amazing that, to be able to enable kids to exercise freely is incredibly important. So thank you. Really appreciate it. And as a sideline, I think I played on opposing teams with Dr. Urschel, and I think we were both more concerned for ourselves than for the children. But anyways, that's an aside. Jennifer Kingdon put a really nice message that I'll just read out loud. My son has had a heart transplant. Sick Kids Transplant Clinic gave us a sheet about exercise that said they needed to have adequate warm up and cool down. This was something we also worked on in prep for transplant games. Transplant games promotes physical fitness in transplant population. So yeah, thank you very much for that, Jennifer. And that's a great point. In our high intensity interval training program for the transplant kids, we've modified the protocol so that they have a longer warm up. And then the intervals themselves are at a slightly lower intensity, but for a longer duration, because we didn't want to do a quick 1 minute intensity, because it takes time for the heart rate to go up and recover. So by having longer breaks and longer intervals, we allow achievement of a higher heart rate and also more adequate heart rate recovery. So it's a really important point.
Yeah, that was something that I found in my research as well, especially with the heart transplant population, with the autonomic denervation of the heart itself. You need time to kind of get that same response to an increase in activity. So it's definitely a good point that you bring up with adequate warm up and cool down.
Yeah, and then Jennifer has put in another great point. I don't know, Jennifer, if you want to unmute yourself and speak to your family's experience, or I can just talk, whatever you like.
Well, let me know if you have any specific questions, but
your last comment
Yeah.
had to do with your child's motivation to exercise
Right.
through the pandemic, and that's that is one of the sort of the inspirations around the work we're doing. Is we want to be able to provide accessible sources of safe and effective exercise. As you know, Sick Kids and Stollery are referral centers that cover Eastern and Western Canada respectively. And so most of our patients actually that get transplanted are not from the Edmonton region itself. And so the hope is to be able to provide supervised effective exercise that's still accessible, universally accessible, and hopefully we can maintain that motivation to exercise even from their own home. But I don't know if there was anything you wanted to add to that, or your family's experience.
I mean, I like the theory, and it's the long-term effectiveness that I wonder about, and how that would be maintained. Like I'm imagining some kind of a group fitness kind of class online where all these kids are on their little bikes and they get to maybe see each other and motivate each other. Kind of like some of the adult fitness that's been going on, especially during COVID. But that's where it's got to be fun and it's got to be motivating in order to keep going, because like you said, accessible is important. I can see them being really keen on it at the beginning, wanting to participate, maybe needing a little bit of parental motivation, but ultimately we want to create within these kids, because mine's not a kid anymore, by the way. He's now like young adult. So he's supposed to be motivating himself. But this is what I'm saying. This transition to adulthood is part of what we need to be planning for, because there's a huge drop-off that happens when they transition from pediatric care to adult care. I can attest to this now, having witnessed it. And they feel very supported. in that pediatric environment. And even as parents, we do. And then when they're thrown into the adult world, it's very different. It's kind of like the transition from high school to university kind of feeling, where suddenly they're supposed to be independent, but if they've had a lot of supports and coddling, then it's going to be pretty tough on their own. And somehow that transition needs to include that intrinsic motivation for why it's important to stay fit, and maybe a collective collaborative feeling of motivation where that carries on, like, oh, you're not pediatric anymore, sorry, hope the best for you, you know. But if there was some carry on where they can still be a part of that fitness group or something that keeps them motivated, this is where my thinking's going.
Yeah, it's I completely agree, and thank you for your input. You know, generally speaking, transition to adult care is a nerve-wracking and fragile time point for everybody involved. There's a lot of you know, when you transition such a patient who's had such a complex and long-term medical history, there's you know, to a whole different team. I can only imagine for families it's very difficult. You know, one of our biggest interests is not, like you're getting at, is not what do we do about their immediate fitness changes. You know, if we immediately improve their fitness, that's just step one, but the harder part is to maintain the changes. And that's really what we're hoping to get at by taking children who may, or their families may perceive them to be unable to sort of exercise this intensity, and show them that they indeed can and can do it safely. At least that's what we hope, and that we can perhaps maintain changes. But in the back of our mind, we're also considering, you know, what are the long-term strategies? Are repeated exposures needed? Do you need something that can permanently be in their home? Or what kind of strategies can we use to sort of incentivize exercise and healthy, active living in this population, for sure.
It's an interesting thought experiment when you look at like the kind of the pediatric to adult, even just in the cancer population, they have a transition to care. They have a young adult kind of person that will follow you throughout if you had pediatric cancer. So it's kind of an interesting thought experiment to think of potentially having some kind of follow through while even after you're done with pediatric care, to be able to have that follow through into young adult and adulthood, to make sure that you're always supported, even if there's just a separate program just for that. And I know that when I did like a Fontaine population like camp, having the kids together and actually talking about like, oh, this is a thing that happened to me and this happens to you, and just having that like social support and that social circle is just so important, that they actually understand they're not alone in this, and that they're actually able to communicate with peers that are going through the same thing.
That's a key thing that happens at the Transplant games. And the important thing about the Transplant games is the pediatric population is also interacting with the adult population, and they're seeing what life is going to be like for them someday, and they're seeing it in a very positive light. And there's a lot of encouragement that happens. It's unfortunate that it's only at that kind of an event that happens, because I really wish that all transplant kids could experience that, even the ones that don't consider themselves athletic. And my son wasn't an overly athletic person, and he was so accepted, even though he wasn't a very athletic person. In fact, there's camaraderie where in a running event, some adults would come run beside him to sort of encourage him to keep going. That kind of a thing would happen. It doesn't necessarily carry on into the adult population if he was then to participate in similar events. But as a child, he was getting that kind of support.
Thank you, Jennifer. And the importance for, you know, peer-to-peer mentorship has been recognized here, and Dr. Urschel, who's on the call, or I guess attending the presentation, he's been leading a lot of work around this in collaboration with Sick Kids, around establishing a peer-to-peer support group. So, you know, this all sort of comes back to the same idea, and the hope, to get at one of your other comments, Jennifer, in the chat box, is that this will be part of a comprehensive program for maintaining the health of these kids, and that would include a cardiac rehab program, but also be part of a peer-to-peer mentorship program. You know, one of the nice things about the MedBike system is you can have up to 4 people at a time. So you could always have, you know, a mentor exercising with you at the same time, or other kids that have had transplants, and you're sort of creating some friendly competition as you accrue points and see who gets the most points and stuff like that. So these are all incredibly important points to consider for sure. Thank you. Sherry has said, COVID has posed an added risk in participating in indoor organized sport for youth. It's a tricky time to keep kids motivated to stay active as choices become more limited to prevent exposure to COVID. Completely agree. And I think this will be a fluctuating thing with time. So all the more reason to be able to establish home-based exercise. Yeah, thank you, Sherry. Does anybody else on the call have any other questions or thoughts? If not, I'd like to thank Amanda for presenting and doing a great job, and wishing her all the best through the rest of her time in medical school. Next week's ATI seminar, we'll be very pleased to have Mr. Phil Walton presenting on the topic of embracing legislative change to improve organ donation rates. So thank you very much, everybody, and see you next week.